Starting Point Coaching and Consulting presents Kairos Conversations, Connecting with Quality, the podcast. Kairos is Greek for the right time, the right season, the right opportunity. This podcast features healthcare quality professionals who share their journeys, their advice, their struggles, how they made that transition into a new and exciting role. My heart's desire is that you find this podcast to be inspirational to you as you make your own journey. Don't forget to share this podcast with your colleagues and friends and rate us on whichever podcast platform you listen to. Thank you for being here. Thank you so much for tuning in today. Today, I am joined by my next guest, Nipaporn Somyoo. Thank you so much for being here today, Nipa.
Brandy, thank you so much for having me. I'm really looking forward to our conversation. And thank you for your platform and getting voices out there and starting different conversations about how we can be better. I appreciate that.
Yeah, I am super excited to talk to you and for the audience to hear your journey. So let's start by introducing yourself to the audience.
Okay, first, again, my name is Nipaporn Somyoo. I go by Nipa Somyoo, and I am a physical therapist by training. And my current role is I'm assistant professor in the Doctor of Physical Therapy program. And I'm co-founder of Scholarnetics, which is a healthcare mentorship and knowledge sharing platform to help provide mentorship to people who need it.
Oh, I definitely want to dive into that.
Sure.
And we'll get to that too. I'm so glad you brought up that piece because mentorship is huge in our space. But let's back up and talk about how did you decide you wanted to be a physical therapist?
Well, it's not the traditional. I wasn't a traditional student in the sense where right after undergrad, going straight into physical therapy. It's a second career for myself. And I was initially in real estate sales right after undergrad. And I made a change. It was in 2008 when the real estate market, where the economy declined, I should say. And I had to think about where I wanted to take the rest of my career. Was it stay in real estate and see how things go? As we know, it was very challenging for probably most of us during that time. And I had to reflect on, okay, what do I like to do? What are some things that interest me? And so I took that approach. I didn't know much about physical therapy. I just started thinking about, okay, I really enjoy helping people and I am fascinated with the human body and I appreciate it so much. And I like exercising. I started doing some research and found physical therapy, started shadowing, applied to physical therapy school. Here we are.
Wow. So what setting of PT do you work in?
So my primary training is in orthopaedics. I have my OCS in ortho. So that's the primary areas I've been in for the past decade, but I have worked in different settings. I worked in acute care. I've worked in inpatient rehab, but majority would be outpatient orthopedics.
So for people who may be listening, who may not know what a therapist does in outpatient orthopedics, I don't want to make any assumptions. Sure. Can you share with them what you did then as a clinical provider?
So in outpatient orthopedic settings, it's different than inpatient, where people are coming in for general musculoskeletal conditions and also neurological conditions. But it's more if they are coming after hospitalization, it's going to be kind of towards that end of continuum of care in a sense where you have people who are typically coming in for neck pain, back pain, knee pain, typical musculoskeletal conditions, post-surgical conditions, rotator cuff repair, neck pain, back pain. People are typically going to be in a position where they're able to come in clinically and be able to just come in for their appointment, which is typically about an hour or so. And then you typically see patients, and it depends on a few factors, but it's going to depend on the patient's needs. Maybe they come in once a week, maybe they come in twice a week for a number of weeks. So very different from an acute care setting where it's typically due to some type of illness. People don't want to come in. They're in the hospital and you see them while they're in the hospital. So very different.
Okay. And I know that you've switched to academia now. So what was your defining point? Like what made you make that switch?
So that was a very interesting time. I had been practicing for a number of years and I was working outpatient orthopedic hours, which can be really long days because people like to come in, or people are able to come in after they leave work, which is in the evening. So I'm working 10, 12-hour days, and I wanted a shift. So I took a position, left outpatient for a little bit, took a position in inpatient rehab. And when I was working in inpatient rehab, we saw patients between the therapy teams 3 hours a day, between occupational therapy, speech therapy, and physical therapy 3 hours a day. So spent a lot of time with patients. And I remember being in rounds with the physicians, with the physiatrists, with the social workers, caseworkers, nursing, and we would discuss patients and discharge planning. And I remember having to advocate for patients quite a bit. And I started noticing this, and I was wondering why weren't people advocating for patients and their patients' needs? And I was really troubled by this. And so I called my mentor and I had a conversation like, I think this needs to change. I don't know what to do. How do we create clinicians who are culturally responsive, who understand their biases, who understand differences, but can provide the best care for patients regardless of any of these factors? And I thought about education, and here we are.
So how did you make that transition? I know that there are clinicians who maybe want to work in academia and don't know how to do that, or don't know what steps to take or how their skills transfer. Can you talk about that?
Well, yeah, it was a process. I would say it wasn't something where I decided overnight that I wanted to go into academia. I actually had to try. I didn't want to, leave clinical care and not be sure about what lied ahead. And plus, you need some experience. So when I was treating full-time clinically, I was able to have positions where I was a teaching assistant in a DPT program. That helped me. And I was thinking, oh, this is something that's interesting. This is something that I potentially can do, but it's a very different role being a TA versus being a course director. So then I said, well, I need some more experience. I need some more exposure to this field to see if this is something that I want, because it is quite the shift from treating patients to now becoming an educator in physical therapy. So I asked around, I tried to create networks. I went online, I started looking for adjunct positions, and I taught in the PTA program, anatomy and physiology. Then I had some adjunct roles as an anatomy and physiology lab instructor. And so that gave me a little bit more insight and experience into the field. And so when I did that, I said, okay, this is something that is very challenging for me. I like a challenge. So it was something that I definitely needed to get better in, and still working on improving. But it was something where it was very challenging because it is a very different role to treat patients, but then educate students who don't have much prior knowledge in the field. And so you have to break things down where students need to be able to digest it. So that was very challenging for me in the beginning. And I've never worked with students before outside of being a TA. So that in itself was really, really, really challenging. And so I took the responsibility to say, okay, how can I get more exposure? How can I get more experience in this field? So if I do apply for different positions, I can say I have some experience in this role.
So for people who want to move into a non-clinical role, like academia or any other role, sometimes they want to know, or often they want to know, whether or not they're going to take a pay cut, right?
Sure.
Because we're paid a certain level as a licensed therapist at the bedside. Was there a huge pay cut? Was it lateral? Was it a pay increase going into academia?
So for me, I think I did a pretty good job negotiating my salary when I first started as a PT. And I think that comes from my prior work experience. I had 10 years of work experience prior to becoming a PT. So I would negotiate my salaries when I started getting positions. And so that gave me leverage at each position I came to. And so for me, it was more of a lateral move. It wasn't much of a pay cut. I will say that when I was an adjunct, I was adjunct and just in these TA roles. I did it in conjunction with my full-time position. So it was a very busy time. My weeks were busy. My days were really busy. And I will say in those adjunct roles, it was a pay cut in a sense because I was looking for experience. And so when I'm working full-time in the clinic, in the clinical setting, in the evenings, I'd be prepping for the courses I was teaching. And that was quite the challenge because my time was limited and I didn't have much of it. But I also knew that I was doing it for a reason. And so I took the pay cut it wasn't a pay cut in the sense where, because I wasn't doing it full time, but I do believe that the rate that they did pay was not comparable to what you'll make clinically.
Yeah, I've noticed that too. I've thought about getting into academia. Mm-hmm. The one thing that holds me back, and this is a conversation for another day, but the one thing that holds me back from academia is the lesson planning. I don't know how well I would do with that.
It takes time to learn because, I mean, as clinicians, we don't receive education in teaching, right? So that's a completely new skill set. I felt like I changed careers going into academia. It's a very different role.
Yeah, totally different. And you can't just do the next thing, go into academia without, like you said, getting some practice and building those skills and, adjuncting for a while so you can see if you like it and how it works. Because like you said, it is totally different.
Yes, it is.
I strongly, strongly believe that safe healthcare starts in academia. What are your thoughts about that?
I 1,000% agree. I am a believer in that statement. I do believe that safe healthcare begins in academia. I think it begins with the faculty. It begins with the curriculum and students learning what's safe, what's not safe, and providing that information. And I think that starts day one of PT school when you're in your foundational courses and you're preparing clinicians. I think that is faculty responsibility in the sense of the curriculum to ensure that we are creating a environment where first students feel safe so they can provide, they know what safe feels like, and then they can go out and create safety for our patients, if that makes sense. But I think that the curriculum plays a big role. I would say I am very grateful to be a part of a faculty where we take this very seriously, and we all play our role in making sure that students understand social determinants of health disparities, health equity, so they can be competent, culturally responsive clinicians when they start treating patients. And this begins when they're presented with case studies, and you're adding those factors in so they can understand that this is a holistic view of the patient. And if you don't consider these factors, are your patient outcomes going to be different? Is your patient receiving the care that they need?
Yeah, because every patient doesn't fit the textbook, right? You learn that pretty quickly as a clinician, and even in your student clinicals, that the patient that you saw in the textbook or the patient that you see in person does not match exactly the presentation that you think that they should.
Oh, I think students are met with that pretty early on when they actually see a true patient, whether that's in an integrated clinical experience or if it's during their rotations. You learn pretty quickly that that's not the case. And people have life. People are humans, so they have life that comes with them, and you have to take those things into consideration when providing care.
Yeah, and our profession, specifically for PT, has moved towards a doctoring profession. Not that everyone who's a PT is a doctor of physical therapy, but I don't think that the DPT carries the weight that it's sold in the academic setting, right? We're taught in the academic setting that, the DPT is this end all, and you're going to get all these opportunities because of the DPT, and you're going to get all this pay for the DPT. And that has not been shown to be the case in a lot of people's experiences. And so with the debt that comes with school and with the DPT not carrying the weight that it's carried, there's a lot of clinicians that are leaving clinical care or deciding that maybe clinical care is not for them, even in academia. Have you seen that to be true in your experience?
Absolutely. I think that we have to, there are a lot of things to consider. And I think that you hit on some great points regarding having a DPT. You have all these opportunities, but I think in the past, and I think it's getting better. In the past, it's like, okay, you can become a clinician, you'll treat patients, and then what? Okay, you can become a clinic director of rehab, but then what? If maybe you don't want to go into administrative role, then what do you do? And I think that people can feel stuck in that sense. But I think with technology, we're learning that there is a multitude of different things you can do with your DPT. Maybe it's not clinic related, but there's a certain skill set that that we learn. We learn how to evaluate, we learn clinical reasoning, we learned how to communicate with patients. There's a lot of different, outside of treating patients, there are a lot of different skill sets you develop as a clinician. But I think that we have to understand that and look at it from a different perspective to see that this is the case. And so I think that people do leave the field because there are other opportunities. And maybe you're not using the DPT in your licensure, but you are using those skills that you have in different settings.
Yeah, a lot of people are saying, okay, well, I want to work non-clinically. I just don't know what that looks like. But they're making that decision even before they've seen the first patient on their own, right? So that just speaks to kind of where the profession has gone. But we do need clinicians at the bedside too, because if everyone leaves healthcare, what's going to be left for our future generations? So how can we practice at the top of our license and really have the value that we're seeking when we're in school to be a physical therapist?
I think first you have to reflect on what impact do you want to have and what do you want to bring to the table. And I think that sometimes there's a saying. I remember I was talking to one of my mentors and I was in a continuing education class and I was saying, I might be moving to a different state. I don't know anyone there. And she said to me, well, solutions are found or founded. And so you kind of think of a way sometimes on how to make it out of that rut in a sense. So what I think about when you ask that question, I think about excellence. And so I think that when it comes to practicing at the top of your license, keep staying engaged, knowing where you are, keeping up with the current research. If you're treating patients, what interventions are going to have the best outcomes for patients? There's a lot of continuing education class. I'd say vet the classes and ensuring that it's from someone that's providing up-to-date knowledge. I think one thing is reflecting on where you're at, because I think that you need to understand, are you bringing yourself and what you can to your patients? And if not, maybe it's not a clinical role. Maybe it's something non-clinical where you find a little bit more value. I think embracing technology, I think seeing all the evolution and then all the advancements and bringing that into clinical care if you're still treating clinically. I think that's one way that someone can practice at the top of their license. There's more information, there's more research, there's more light being shed on health disparities, health equity. Reflecting on where you're at in that space and see where you can help and see where you can advocate and see how you can treat patients with a different lens.
Yeah, being innovative in our treatment approaches, right? So not just doing the typical, and I have an acute care background, so I often give examples from the acute care space, but not getting into the rut of, I'm just ambulating the patient up the hall. What kind of things am I doing with the patient to help build the patient for what they may need next, whether that's balance training or obstacle negotiation or getting them distracted while they're walking or simulating the grocery store environment or, curbs and steps and how do they get in and out of restaurants and how do I simulate that in a treatment session, but really, not just doing the task of therapy, but really thinking about how I can help this patient move to the next level, whatever that level is for that patient.
Yeah, I agree. Just making it rigorous enough for the patient to go on and continue their life, especially if you're in the acute care setting. I've worked there a little bit, so I understand and I think that people can get in a position where it's like, okay, you're burnt out and you're seeing all these patients' productivity and you don't maybe have the bandwidth or the time to spend to make it meaningful for the patient, to make it to help push them to a point where they need to be pushed, not a little bit, not just bare minimum, but making it meaningful for their experience and for their outcomes and meaningful to them is really important.
Yeah, and so that our treatment looks different than the personal trainer's treatment or the nurse's treatment, working with the patient or, someone else is working with the patient should look different than what we provide should look different than someone who has a different skill set.
Oh, absolutely. Skilled physical therapy, right? It should be something that we're using all this knowledge that we learn in physical therapy school, all the knowledge that we learn through our experiences and how we can, I agree with that so much.
Yeah, I mean, that's just a hot topic for me because I see it all the time and I see, how we can kind of downplay the skills that we have and what we have to offer. And, so for those who are still in clinical care trying to decide, if they want to move to a non-clinical role, but, maybe they still want to have their leg in to, a clinical setting, really take the opportunity to see where you can add value, to see where you can be innovative, to see where you can practice at the top of your license, whether you're a PT, OT, a speech language pathologist, whatever your role is, because that is going to help people to see you different when you go into your next non-clinical role, because they're going to see you as the expert that you are.
Absolutely. I agree with that. And we tell our students all the time, give people a reason to come see you. They're coming and speaking from an outpatient perspective, they're spending this copay. They're spending their time, which is an unrenewable resource, to come see you. Give them a reason to come. Give them something that they can't do on their own, that they can't get somewhere else. Give them a reason to want to come. And I think that going back to another topic we just discussed is that comes in the curriculum. That comes when you're preparing future physical therapists, and them understanding you are a movement expert. That's how you're seeing. That's the value that you bring, and don't devalue that. So I agree with you.
Hi, friends. I have found that when clinicians decide that it's time to leave the bedside, often it's like throwing darts at a board. They just want out and will take almost anything just to move into a non-clinical role. I have always recommended taking the time to really identify your strengths, passions, and skills, and what will fuel you so that your next role is your best role. I couldn't find a tool specifically for healthcare professionals that would provide the depth needed to get a really good career evaluation. Until now, I am so happy to recommend the Stream Ahead assessment created by Career Clinic. It's the profile that I wish I had created first. Stream Ahead is thorough, comprehensive, and frankly spot on. And yes, I have personally taken it myself. I'll share the link in the show notes section of this podcast. You can thank me later. So I want to switch gears a little bit. I know you brought this up at the beginning, and I want to make sure we have time to talk about it. You talked about your role in Scholarnetics. So can you tell the audience what Scholarnetics is?
Yeah, absolutely. Scholarnetics is, so a couple colleagues and I were discussing, like, what do we need in healthcare? And I can say all of our roles, you need someone to help cultivate and help you thrive. And so mentorship is so important. So Scholarnetics is a healthcare mentorship and knowledge sharing platform hub, in a sense, where you can connect with other clinicians. Students can connect with other clinicians, and mentorship, basically. So being mentored, becoming a mentor. And we really value this because we understand the value that mentorship has played in our career paths. And so it's just providing access. So it's more so access, providing access to individuals who may not have access to clinicians. So for instance, when you are a new graduate, you have your first position. I've experienced this myself, where you go into a role and they say, oh, you'll get a mentor, you'll have mentorship. And then next thing you know, you're treating your full caseload and crickets, right?
Yes.
Right.
Yes.
And one of their selling points is mentorship. And you're by yourself, you're trying to manage a full caseload as a student. So it can be different. So now you're out there on your own, right? You're managing you're managing patients, your patient caseload, and also you might be supervising PTAs, techs, and so forth. And maybe you need some mentorship on how do you manage this? How do I deal with this potential burnout that I might have? How can I receive some mentorship or advice on how to navigate a difficult situation that's not biased, right? So sometimes you don't want to talk to your boss about it because there's a power dynamic there, unfortunately. But where can you have someone's opinion that matches some of your aspirations? Maybe they've taken a similar path and you're looking to go down that same path. And so similar to what you're doing, how do you provide this information to people who need it, who are looking to maybe go into a non-clinical role. Like, how do I have that conversation with someone and where do I get started? And just being able to pick someone's brain, I think that's really important. So I'm a true believer in mentorship. And I think it's something that not everyone may have direct access to. Maybe not everyone can afford to go to a conference where you're networking. Maybe their job is not supplementing that or what have you. So it's just a way to leverage technology to keep sharing information.
So how do students get matched with a mentor? So you have like a catalog of mentors and you have students that apply to the program. Like how does it work?
Right now we are in our beta phase. So right now we're just looking to right now we're getting mentors and we're getting mentees. And so you'll create a profile and there's an extensive algorithm that is not my strong suit. That was built by people who know how to do those. And then it creates, and you can say what you're interested in, your interest, your specialty, and then it matches you with a mentor. And then you have the power to, you know what, this is not a good fit for me. Or maybe it is. Can you match me with someone else? And so again, right now we're in our beta testing. We're just starting to launch. So we are looking to gather feedback to see how we can improve moving forward.
Okay, so would it be helpful can people, if I included the link in the show notes, would people be able to see it now, or is beta phase invite only?
Yes, they absolutely would be able to sign up. So when I will give you that information and they can click on it and then enter their information, and then we'll be getting back to people. And then you'll receive our newsletters on the progress, how everything's progressing, I should say.
That's awesome. Because you're absolutely right. There isn't a lot of mentorship available. And even though it's promoted that it is, there isn't a lot of mentorship that's out there. So I'm glad that you're providing this and making a way for people to connect with mentors that they may not have otherwise met because maybe they live on the other side of the United States.
Sure. Yeah. And that's what it's about, just creating access. And we really believe that it's necessary because we've experienced mentorship and the power of it.
So how can people connect with you?
Well, you can connect with me on LinkedIn, and also there's my social media page, which I'm just starting to get up and running. It's Nipa Somyoo PT. That's my Instagram handle, or as I mentioned, LinkedIn.
Okay. Any parting words for the audience?
I think some important things to consider is, just looking to see, reflecting on, where you want to be. And I know this sounds super cliche, 5 years, 10 years, and you may not know, but find what interests you. I think that's a big driver because you're more motivated to do things you're interested in. So I think that's huge. Finding a mentor I think that's really important as well. I think, and being steadfast with things, it's a process. It takes time, and you might not know where you want to be. You may just know that I want to go into a non-clinical role. But before jumping into any non-clinical role, figuring out what that looks like to you and maybe trying out some different things. I remember a wise person has said one time, there are a lot of opportunities out there sometimes, and sometimes you might not be sure. If you walk through a door, you might not find that it's for you. You can walk back out and you can find another door. So I think that that's really important. So maybe something isn't for you. Maybe same thing with being in a clinical setting. Maybe you realize patient care is not something that you want to do full time. And that's okay. But I think recognizing that so you can provide the best care for patients, because if you're in that role and you know that that's not something you want to do and you're coming in and not showing up as your best self for your patients, that's not fair to them.
I love that, because you said if you walk in a door and it doesn't work, you could walk out the door. So no decision is permanent, right? I think sometimes we think that, oh my gosh, what's going to happen if I make this decision? It's the wrong decision or it doesn't work out. Hey, you can try something else.
Absolutely. I remember my brother, I was taking a new job and I said, what if I don't like it? He's like, well, you can always leave. And I was like, oh, you're right. And then I just needed to hear that. I just need to hear that it's not permanent.
Yeah, it sounds so simple, but I think we forget that, and it's worth saying. So I'm so glad you said that, Nipa.
Thank you so much. Thank you for this time. I really appreciate just having this conversation with you.
I appreciate you being here. Thank you. Thank you so much for listening to the show. It would mean a lot if you would share this episode with a friend or a colleague. I would be honored to encourage them in their journey too.